as a pedicle flap. So Dr. Farah, please start.
Yes, sir. Sir, am I audible?
Yes, please.
Hello everyone. I'm Dr. Farah Nas, resident plastic surgery, PNS Shifa Hospital, Karachi. So the article I'll be presenting today is individually tailored approach to reconstruction of complex defect using the versatility of lateral circumflex femoral artery system based pedicled flap. This was published in Journal of Plastics and Reconstructive and Aesthetic Surgery in January 2022. The authors are Tahsin Oz Akartar and For Barres, Bengal. So some things about the author. Dr. Tahsin is a member of Faculty of Development of Plastics and Reconstructive Surgery at the University of Pittsburgh Medical Center since 2011. He has received the Young Plastic Surgeon Award by European Association of Plastics as Reconstructive and Aesthetic Surgeons in 2007. His areas of interest include microsurgical reconstruction, reconstruction of trunk, wound care, lymphedema, lipedema surgery, and rhinoplasty. He has written over 40 peer-reviewed articles and book chapters, mostly related to microsurgical reconstruction, reconstruction of complex defects, and rhinoplasty. Introduction is, in this article, authors have presented their experience with pedicled flaps from lateral circumflex femoral artery system. The descending branch of LFCA system was used as the main pedicle. They used this flap on various locations for reconstruction of defects around the upper thigh, perineum, lower abdomen due to multiple etiologies. It was used as a composite flap, components tailored as requirement. The number of patients were 22. In one patient, 2 flaps were done, so the total number of flaps were 23. The ages ranged from 4 years to 71 years. The duration of the study was from 2007 to 2015. This is a case series. The inclusion criteria was all those defects that were deemed not manageable with other local or simpler options. So skin pedals were centered over the perforators identified on handheld Doppler preoperatively. Components that were being included in the flap depended on the defect requirements, ranging from fascia lata, vastus lateralis, vastus intermedius, and rectus femoris. For fasciocutaneous flaps and vastus lateralis, including myocutaneous flaps, dissection of descending branch of LFCA was done. When rectus femoris and vastus intermedius were included, then their muscular branches were also kept intact. These are all the pictures from the original article. Flaps were taken for surface-only defects. Fascia lata was included for full-thickness abdominal wall reconstruction with predisposition to hernias. Muscle flaps were used in defects with exposed viscera, cavitary defects requiring bulb, and areas with history of infection or osteomyelitis. So there were different techniques to transfer the flap due to different locations in which the flaps were being used. For ischio-gluteal and trochanteric lesions, flaps transferred over the tensor fascia lata. For groin and ipsilateral abdominal wall, transfer was done directly without tunneling. For central and contralateral abdominal wall and groin, transfer was done under the rectus femoris and sartorius. For perineal and perianal region, transfer was done under rectus femoris and over the abductors. Lunar side was primarily in 20 cases, and in 3 cases, split thickness skin grafting was done. In post-op period, the positioning of the patients were also kept different. When the pedicle was transferred under the rectus femoris, the leg elevation and hip flexion at 45 degrees for 48 hours was told to the patient. For ischio-gluteal and trochanteric reconstructions, patient was placed in contralateral decubitus posture for 2 weeks. Defect locations were 10 for abdominal wall, including groin and pubic reconstructions, 9 were ischio-gluteal and trochanteric reconstructions, 4 were perineal wall reconstructions. Mean time for follow-up was 28 months. So this is a chart from the original article. It shows the variety of flap components used to cater the depth in different locations. Defect sizes ranged from 6.6 to 30 by 35 centimeter. Maximum depth of defects was between 7 and 18 centimeters. Flap sizes ranged from 9 by 6 to 38 by 20 centimeters. 2 flaps were faciocutaneous perforator flaps, 4 were myocutaneous with muscle sparring vastus lateralis, 10 were myocutaneous with segmental vastus lateralis, 5 were myocutaneous trimuscle only, and 1 was trimuscle only. There was no partial or complete flap loss. Small wound lesions in 2 patients was seen, which healed with local wound care. In 1 patient, abdominal wall hernia requiring reconstruction was seen. Recurrent osteomyelitis of hip joint requiring further debridements and advancement of the flap afterwards was seen in 1 patient. In 1 patient, exostrophy of bladder who required persistent cystostomy drainage, abdominal wall hernia was seen, which required reconstruction. So the strengths of this study are that this shows the use of these flaps in wide variety of locations and adds a viable option to the armamentarium of a plastic surgeon for reconstruction of complex defects. And these flaps can be used by surgeons well versed with the anatomy of LFCA and are doing these procedures in their everyday practice. There are some limitations as well, as it is a case series, and the pedicle length is also not addressed by the authors in the article. This also shows the use of this flap by a single experienced surgeon who has also done the free counterparts of the same flap. And despite the standardization of the technique, outcomes are not always similar to for all the surgeons. Thank you.
Thank you, Dr. Farah.
Thank you, sir.
Thank you very much. Any comments, any discussion, anything anybody wants to?
Hassan, I am particularly interested in the donor site morbidity. Did they discuss the donor site morbidity? That is the important thing.
Sir, they did not discuss the donor site morbidity.
So is it just a comparison of free versus pedicled?
That is one.
No, I think it's a different articles. One is speaking about the pedicled, and the other article is discussing the free flap.
Okay, let's listen to the other article as well.
I think we can proceed for the second article, then we'll discuss both together because I think they are very closely related.
So sorry, I got disconnected. Sorry for the poor internet connection.
Yes, we were discussing about the donor site morbidity, and we will suggesting to proceed for the second article because they are closely related. Then we'll discuss both articles together.
Okay, fine. So Dr. Abdul Rasool will present the second article, please.
Hello.
Ji Abdul Rasool, you're audible.
Can everyone hear me?
Yes, we can hear you.
And my screen, is it shown to everyone?
Yes.
I'm sorry, I'm having a problem. So my screen is shared?
Yes, exactly. Perfect.
Thank you. Assalamu alaikum, everyone. My name is Dr. Abdul Rasool. I am resident plastic surgery at PNS Shifa Hospital, Karachi. Today, the article I want to share is titled as Anterior Lateral Thigh Osteomyocutaneous Flap in the Head and Neck, the Lessons Learned. So this article was originally published in the journal Microsurgery in February 2022. So, few things about the author. The author of this article is Stephen B. Kennedy. He is Associate Professor at the Department of Otorhinolaryngology, Head and Neck Surgery, Pennsylvania, and Medicine, Philadelphia, USA. The author is also Director at Microvascular Head and Neck Cancer Surgery, University Hospital of Brooklyn. So, introduction. In this article, the authors have shared their experience using anterolateral thigh osteocutaneous flap, that is ALTO, for reconstruction of through and through composite defects of the head and neck. The ALTO flap is based on descending branch of lateral circumflex femoral artery and its deep myo-osseous branches that supply to the vastus intermedius and the femoral shaft. So only one case series have been previously published on this topic. So this is the first study to incorporate prophylactic intermedullary nailing. Patients and the methods. The number of patients in this case series are 23 patients, and the age group ranges from 47 to 92 years, and the study duration was 2009 to 2020. Inclusion criteria in this article are all patients with large through and through defects of head and neck for reconstruction. So the surgical technique. Initial dissection of the flap was done as a standard method. In dissection, excuse me, everybody can hear me. I'm in doubt.
Yes, Abdul, we can hear you. You're very clear.
Thank you. So the initial dissection of the flap was done as a standard method. In dissection, special care was taken to preserve the branches of vastus intermedius muscle. A cuff of vastus intermedius muscle was harvested with its associated periosteum down to the femoral cortex. The superior and the inferior osteotomies were performed to excise the segment of femoral cortex with the remainder of the soft tissue flap. So after initiating prophylactic fixation, the author began to cut down the femur intermedullary nail as deep indicator of entering the narrow space. Post-operative period. So patients were mobilized and received venous thromboembolism prophylaxis according to the standard pathway for pre-flaps at author's institution. On the first post-operative day, patients were assisted with transfer to the chair. On the second POD, they were provided with the walker and cleared for partial weight bearing with assistance for short distances. And from the third post-operative day onward, they were permitted to bear weight as tolerated. So results. In results, 8 patients who underwent ALTO flap reconstruction experienced post-operative complications that include hematoma, partial flap necrosis, wound dehiscence, and femur fractures. So in case number 14, in their study, they experienced femur fracture on the second post-operative day when the patient was mobilized for the very first time. So that event basically prompted the decision to subsequently perform the same-day prophylactic fixation prior to the flap harvest. There were no differences in the operative time prior and after the implementation of the prophylactic fixation. And in 2 ALTO flaps, significant variation in the anatomy of the branches that supplying to the femoral cortex were noted. So discussion. In 2008, a series published of multi-flap reconstruction for the large head and neck defects reported increased length of surgery time to 13.8 hours, ICU stay to 4.3 days, and overall stay to 11.5 days compared with the single flap cases. So in author's experience, double flap reconstruction increases the donor site morbidity. In a systemic review, it is concluded that double free flaps does not increase the complication rates nor operative time as compared with the single free flap performed with locoregional flaps. In current ALTO flap series, The overall risk of the major complications was 36.4%. In comparison, subscapular cardiac flaps have reported risk of 10 to 48%, whereas double free flaps carry the risk of 33 to 0.3%. Strengths of this study or this article: high risk rate and a viable option. High success rate and a viable option for a large composite defects in head and neck, and the alto flap may provide considerable advantage in the length of bone up to 20 centimeters, with multiple bone segments up to 3 in author's experience. And the alto flap offers a single donor site and 2-team approach. Thus, no need for repositioning of the patient as compared to the subscapular mega flap. These are the strengths of this case series. Limitations. The limitations are single center experience. Basically, this is a single center experience and a limited sample size. It is underpowered to detect the differences in the outcomes of this case series. So despite the standardization of the technique, the surgical outcomes may not be similar for all the surgeons. Conclusion. The alto flap is preferred at author's institution for reconstruction of the large, complex, multi-component head and neck defects. To address the risks of fracture, fallen femur harvest, they have implemented prophylactic fixation. So these findings are encouraging in the adoption of the alto flap and its utility in the head and neck, but there is a need for further collaborative multi-institutional studies to compare the outcomes between alto, double, and subscapular system flaps. That is all. Thank you, everyone.
Perfect. Thank you, Dr. Abdul Rasul. Dr. Rana, your comment?
Yes, thank you very much. So just as I started off saying that we chose these because we wanted to discuss and read about the versatility of the anterolateral thigh flap and how its use can be increased. As Dr. Zia asked about the morbidity in the first presentation. So they've just told us that they were able to close the donor site in 20 cases, and in 3 cases they used split thickness skin graft, and they did not find any donor site morbidity. They haven't really calculated if there was any decrease in extension strength or any other disability in walking after taking the rectus femoris or the vastus lateralis muscle. But the data they have given us, according to that, they didn't have any donor site morbidity. As far as the second paper is concerned, I would still be worried about using a large chunk of the femur and IM nailing it because they only had 1 fracture, but I would still be worried about taking that flap. I would still consider taking a osteocutaneous fibula and if needed, a radial forearm flap with that.
Thank you, Dr. Rana. I have a comment about, actually, in the second paper, particularly, especially in the second paper, I don't know why I couldn't catch the gap in the study between the knowledge and the need for the study. I don't know, I didn't catch that, why he's doing the study and why he published the article. Of course, it's nice to publish a new technique and to add it to the armamentarium of the flap reconstruction techniques. But actually, he didn't compare it to any other flaps. I was expecting that he will compare it to the free fibula or something like that. Especially it's also from the lower limb. It will be 2 teams techniques and so on. He compared it, or he pointed to the subscapular system, which is actually, I don't think it's inferior to the free fibula flap. Do you have any comment about that?
Yes, because I think the main aim of doing this flap was having a large chunk of bone, and you can't actually get it in a subcapsular flap. So these were large defects which needed bone and large soft tissue coverage. So I absolutely agree with you. He should have in detail discuss its comparison with the free osteocutaneous fibula, and then we would have been able to be in a better position of thinking about adapting this flap or not.
Thank you, Dr. Rana. Any comment from other audience?
I have some comments.
Yes, yeah, please.
If he is using a composite ALTF, it would mean that it is going to be a very large defect that he is reconstructing. And in large defects, usually we require a bone that we can osteotomize, because to recreate the mandible, we have to do osteotomies. And I wonder if a single cortex of femur, we can do osteotomies on that. We are very fortunate to have Farooq Shahzad in the audience. It would be extremely valuable if he can give his opinion on how likely it is that this flap, a composite bone including ALTF, will become popular in future.
Hello, Dr. Zia.
Hi.
Hey, so I agree with Hassan. I would get very nervous taking a big chunk of the femur, especially since we have really good flap options available. Just like Dr. Hassan, my go-to flap for a bone defect is a prefibula. If for some reason that is not available, if it's already been harvested before, or if there's severe peripheral vascular disease, or if there's some congenital vascular anomaly, then if I need a big chunk of bone, then the iliac crest is a great option, because that's usually spared. I do a lot of head and neck. And so for head and neck purposes, the scapula is not a great option, because it's difficult to osteotomize it, and it's difficult to put dental implants in. For a large defect, the other thing is that I would want independence of the bone and the soft tissue component. So a lot of the times I find it easy to just do, for large defect, just do 2 free flaps. So just do a bone free flap and then do a soft tissue free flap with it. The problem arises in vessel depleted necks, multiple surgeries, radiation, where you don't have a lot of recipient options. You can still get recipient vessels in those situations. You can still go to the internal mammary vessels, for example. But I would imagine that would probably be a situation where you have a multiply recurrent tumor, previous adjuvant treatment, all the vessels have been used, and you don't have any options, and you can only do 1 free flap. Maybe in that option, in that situation, I see an osteocutaneous ALT being potentially as a last kind of resort flap. But otherwise, I agree with Hassan that I would, I'd be very nervous taking a big chunk of femur. Now, I think the medial femoral condyle is a great flap, and I have done it for specific reasons. So it's great when you need a small chunk of bone, for example, for the wrist. But if you need a large chunk of bone, I would be very nervous taking a large chunk of the femur and then prophylactically nailing it. I think that's a pretty big donor site morbidity.
Thank you, Dr. Farooq.
It was conventionally considered that the osteocutaneous fibula does not have a great skin paddle. But recently, we have been seeing huge skin paddles being raised in osteocutaneous fibula. So I think the fibula is gaining much more weightage than previously, and I find it difficult to find an indication for this osteocutaneous ALT.
I think also for osteotomies of the fibula to make segmentation, it will be much more easier to do it for femur.
As regards the first article, in abdominal wall reconstruction, when we take the fascia lata, do we include it in the transverse pedicle, or we just take it as a part of ALT?
Sir, they haven't described it in this article that they did take that or not. But I've done a couple of such flaps, and I have taken the transverse pedicle with it. Because
yes, I think that would be the logical thing to do.
Sir. And usually it provides a very good, the facial data provides very good abdominal wall reconstruction coverage and prevention of hernia.
Fantastic. Lovely. Thank you. Thank you very much, Rana Hassan. You took up the challenge of taking this journal club today at a very short notice, and I truly appreciate that. Any other questions or comments from the audience?
I would like to thank Dr. Rana and his team for the choice of the article, because they're covering a wide scope for the application of the lateral circumflex iliac, lateral circumflex femoral artery, and its application either pedicled and free. And also I thank you for covering this journal club in this short time. And thank you for Dr. Rana and his team, Dr. Abdul Rasul and Dr. Farah.
Most welcome. It was a pleasure to have the opportunity.
Thank you.
Thank you, Dr. Rana. Thank you, Dr. Farah. Thank you, Dr. Abdul Rasul. It was nice to having you today.
Thank you very much. Thank you. Bye-bye.
You look in the office, Dr. Rana.
Yes, I'm in my evening clinic right now.
I like background.
Thank you very much. Thank you. You can have a better look.
Oh, a lot of certificates. You have to read it on this.
No, they're just up there.
Okay, nice to meet you. Okay.
Nice to meet you. Thank you very much.
Thank you.
Bye-bye, everyone. Thank you. Bye-bye.
Thank you. Bye.